Good morning, everyone. Malawi. My name is Natasha Adodo. I am the Communications and Engagement Officer here at the Scotland-Malawi Partnership. Welcome, friends, all protocol observed. For everybody in the room at the moment, there are no fire drills planned out for today, so if in case the alarm does go off, please let's all evacuate. Our toilets are located right outside, right by the entrance. However, only the disabled toilet at the moment is actually working. We have Wi-Fi in the room, which is the assembly room's internet. You will find that in on your network services. And for those joining us online, please make sure to introduce yourself in the chat. So your email, your organization as well will be quite important. After the meeting, seeing as the meeting is going to be recorded, the meeting will be put on our website as an archive. So you can always go through that right after the meeting. I'd love to thank MEIRU for the collaboration and support that we've had the last 2 weeks. It's been a pleasure working with the MEIRU team, and I'd like to introduce Marcia, Kamanga-Wawanya, to come give us today's overview.
Good morning, everyone.
Morning.
I think my voice, I have a cough, so forgive me. Thank you so much. It's a pleasure to be in Edinburgh today. I'm from Malawi, first time in the UK, so I'm very honored to be here. And thank you all for honoring our invitation and coming to this event. We hope that you will find the documentary exciting as we have found it. It's been a couple of months worth of work, but we're happy with the output, and we hope to get feedback from you as well. I'm just going to run you through the program. So we are going to have a few speeches from the beginning. Professor Mia Crampin will give us an overview and introduction to MEIRU. And we will also have Dr. Wisdom speaking about the Generation Malawi project. And we also have Dr. Sharifa, who's going to tell us about the methodology that was used in producing the film. And then we'll also have time to watch the 2 episodes of the documentary that are ready, episode 1 and 2. And lastly, we'll also have a Q&A session. So after we watch the episodes, you can ask some questions. Otherwise, I'm sure it'll be a very good time. Thank you all for coming.
Thank you, Marcia. So I'm Mia Crampin. I'm an epidemiologist by training and currently the director of the Malawi Epidemiology and Intervention Research Unit, where I've been working in MEIRU and its predecessor since 1998, so quite a long time. And thanks to everybody again for coming today, particularly thanks to the Scottish Malawi Partnership for hosting us, really much appreciated. I'm particularly happy to have our funders, Wellcome and UKRI represented here, Viv and Caitlin in the room and Samantha online. Your presence is really appreciated, and thanks everybody else for joining us. So I'd like to tell you a little bit more about the Malawi Epidemiology and Intervention Research Unit. We're an independent research unit that's formed as a partnership between the Malawi Ministry of Health, the Kamuzu University of Health Sciences, which is the Malawi College of Medicine, London School of Hygiene and Tropical Medicine, and latterly the University of Glasgow. With a much broader range of collaborators, including a key one in mental health at the University of Edinburgh. So we've existed as MEIRU for about 10 years now, and it's born of a much longer term project known as Karonga Prevention Study, which started in rural Karonga in 1979. So over the years, we've conducted a lot of research in infectious diseases and vaccines, but since the improvements in health in Malawi and adult health in particular, largely brought about by the unbelievably successful ART program for HIV, we've been turning our attention to long-term conditions more generally, including cardiometabolic conditions like hypertension, diabetes, stroke, and heart disease. And then in the last 4 years, as it's become apparent that it's an emerging problem that's probably already been there for a long time, mental health conditions. All of these conditions are really hard to study compared to acute infections. And the causes and the drivers of ill health in adulthood are often set much, much earlier in the life course, and sometimes even in prenatal health prior to conception, and in many cases, genetic susceptibility plays a part. And to really understand what's going on, researchers need to look at whole populations, not just those finally attending health facilities when they get sick, and they need to follow them over many years. And it's also important in countries like Malawi, where the experience of health and exposures in rural areas is so very different from urban living, to study people across that divide and recognise that people do move back and forth from those settings. Unfortunately, this is the type of research that MEIRU is set up to do, and we excel in it. We have unique research platforms in rural Karonga in the north of the country and in urban Lilongwe. And we have a huge amount of support from our partners in Malawi through the Ministry of Health and the facilities and the communities as well. So through this strategic change in direction from infectious diseases to long-term conditions, and with the support of our key funders, Wellcome and UKRI, the UK Government Medical Research Council, we've established a huge programme of longitudinal population study to explore these long-term conditions and to understand the role of many factors: nutritional, social, genetics, environmental, infections, and to see how they're driving these common conditions that we see around us: stroke, heart disease, again, depression, anxiety, and others. We seek to understand where those first seeds are sown that lead to these later conditions, and it's not as simple as it seems. For example, although obesity and unhealthy diets and lack of physical activity increase your risk of diabetes and heart disease, it's clear that poor nutrition early in life and chronic inflammation due to early infections predispose people in countries like Malawi to these conditions in a way that's just not seen in high-income settings anymore. So what are we trying to do? Well, we've established two large programmes of work, one of which is called Healthy Lives Malawi and the other Generation Malawi. And in Healthy Lives Malawi, we track a rural and an urban population from birth to death through demographic surveillance, soon to be on over 100,000 people in the south of Karonga district and traditional authority Wasambo area, and in the Lilongwe area 25. We're supported by a large group of amazing community key informants and we capture household and individual birth and death data in real time. In Healthy Lives Malawi, we also conduct total population surveys of long-term conditions, including all these conditions I've talked about and many others. And we screen for depression, anxiety, and alcohol use disorder. We're currently approaching 30,000 people in the latest survey and aim to reach 50,000. And to support this work, we've established and run NCD clinics in both settings, and more recently overseen by Dr. Stewart, mental health clinics in both Area 25 and Chilumba, because no mental health services existed there before. But to really understand the role of early exposures in physical and mental health conditions, we need to go right back to the pregnancies and births. And so we've established what we call the Generation Malawi Birth Cohort project, which was initiated through two awards, one from the UK government through the UKRI MRC with PI Andrew McIntosh over there, and another one through the Wellcome Trust, the Healthy Lives Malawi project, on which I'm the PI. The UKRI funding particularly funds the mental health elements, and the Wellcome funding focuses more on the physical health so far. So in this film, you'll hear about our work in pregnancy and very early life, but it's important to understand that the value of birth cohorts increases the longer you follow people for. And there are birth cohorts in Europe and South Africa that have followed children born to birth cohorts throughout the course of their lives, to the birth of their children, and in some cases, even to the birth of their grandchildren. And we aspire to be the first birth cohort in low-income Africa that actually gets to that stage and achieve that length of follow-up. And we are delighted to say that we've just been awarded 4 more years of funding for the Generation Malawi birth cohort by UKRI, so we can continue to recruit families, to increase sample size and follow our infants to at least 3 years of age, which is really good news. So before we turn to the film, I'm going to ask Wisdom Nakanga, who's a clinical researcher in Malawi, employed through the University of Edinburgh, but seconded back to Malawi, who's been leading the implementation of the Generation Malawi birth cohort together with Rob Stewart. So over to you, Wisdom. Thank you.
Thank you. Thank you so much, Mia, for that warm introduction. I'm a postdoc at the University of Edinburgh, but for the past 2-3 years, I've been based fully in Malawi, working at MEIRU to establish this unique, one of a kind birth cohort, which we're calling the Malawi, Generation Malawi. And the ambition of it is to understand the life course of health and diseases in our setting by following about 5,000 babies from the time they're born until later on in life. So how we're doing this is recruiting expectant mothers and their partners during their second trimester. I conduct a very long questionnaire. It's about 3 hours long, where we assess almost every single aspect that you can think of, from socio-demographic status, history of medical illness, mental health conditions as well, including depression, anxiety, PTSD, intimate partner violence. We do a battery of measurements and also collect all the samples that you can think about, including blood, saliva, urine, stool, swabs, and then we follow them again at the third trimester, and even at delivery. That's when we recruit the mother, the babies as well, and we follow the mother, the baby, and the partner at 1, 6, and 16 weeks follow up. And now we've started doing our 1 and 2 year follow-ups as well, and then planning as well our 3rd year follow-up. Just as Mia said, hoping to be following these babies up in this cohort up for a long period of time. So truly, we're collecting a huge battery of data, and it will be a good resource which we can all use now and even into the future as well. Just even from the initial work that we have done, there's hundreds, if not thousands, of research questions which I'm sure everyone is already thinking about that we can answer with the data that we've collected, including things like how does the parental mental health and even the bonding between the mother and the fetus and the infant, and even as the child is growing up, how does the interaction impact the social development of the baby as well? Looking at how do severe climate events impact the maternal stress and even the birth outcomes as well. Things of like looking at genetic markers of which help determine birth body composition at early life. What are they, and even how do they predict or determine someone's progressing to developing long-term conditions, for example, diabetes and hypertension. So there are so many questions which we're hoping to answer through this work that we have started, and hoping going on into the future as well. The main thing that we're trying to do is create a resource which will be able to attract more funding to Malawi to help other researchers, not just in Malawi, but also elsewhere, to answer research questions which not even us have thought about, but then can use the same data that we're collecting to answer those research questions, and even encourage other researchers from here and in the global worldwide as well to use the platform we're creating and the data that we're creating to answer research questions, which so that we'll make sure that the cutting edge research that is being done across the world can be applicable and is made applicable in the Malawian context as well. I think last but not least, I just want to say, yes, Mia, myself, and Marcia here representing this study, but there's a whole team of us, from the field interviewers to the team in the lab, the nurses, the data personnel, who are working really hard to collect all this data as well. And last but not least, as well, I want to acknowledge the participants as well, especially the mothers. Like I said, it's a long interviews, lots of follow-ups, and so we want to acknowledge the collaboration between the MEIRU team and also the participants in the birth board, who have made everything possible, including this documentary that we're about to see. Yeah. So thank you so much. I'll hand back to Amelia.
Thanks, Richard. So let's turn to the film you're about to see. So its creation is funded by a public engagement award from Wellcome. And we asked for funds to be able to provide some human context to the data that we're collecting. So we wanted to ensure that researchers, policymakers, stakeholders who use our data and our findings can see the people, or at least some of the people behind the data, to understand their hopes and fears, their successes and failures as parents, the challenges around raising their children, some of the good days, some of the bad days, you know, that we all experience when we're bringing life into what is a rapidly changing world. So all the children born in Generation Malawi are precious and all will be loved. Some have been planned for years, some have been waited for years, some are unexpected, and some will have more opportunity than others to thrive and achieve in life, and some will experience hardship and poor health. And we hope that the work that we're doing in Generation Malawi will have impact in ensuring a healthier start for children in Malawi and other countries like Malawi. Some of the Generation Malawi team here are present, not just the ones you've heard of, but others also. And I hope at the end there will be a Q&A session, so take your notes and be ready to ask us anything. So the film you're about to see first is the first of 3 planned episodes, and you'll see the second one as well today. So the second one in particular is hot off the press. Marcia and Sharifa have been working 24/7 with the filmmakers to get it all together. So we were editing weird subtitles late last night, early this morning. So if you see any weirdness, it will be ironed out eventually. But this is really, yes, this is the premiere of that particular film. So let's call this the director's cut, and we will get down to the polished version of episode 2 in due course. Just to say, a lot of the stuff is from the women and the families themselves, and so they're obviously speaking in their local languages, which is Chichewa and Chitumbuka, so there are subtitles. So do feel free to shift yourselves around to see the bottom of the screen if you can't already, because otherwise, if you don't read the subtitles, you'll miss all the interesting stuff. Okay, so here is episode 1. We're up in Malawi, I hope.
Welcome. This is one of 3 episodes of the series Growing Up in Malawi. Throughout the series, we will hear from mothers and their families about their experiences of raising a family in Malawi. Our participants include 10 women from Area 25 in Lilongwe and 10 women from Chilumba in Karonga district, where MEIRU is running the Generation Malawi study.
Ndine Amelia Sangano, nina vyaka 28.
Dzina langa ndine Emma Chanza, ndimakhala 25C.
Ine ndine Justina Msisia, kuno kukhala kwa Bonji.
Ine ndine Roda Mkorongo, kuno kwa Vunda Kulwa Chilumba.
Malawi is a unique time point in the health and well-being of our communities. Infectious diseases and poor nutrition are still common problems, and at the same time we're seeing a rise in long-term mental and physical health conditions, for example diabetes and hypertension. Moreover, the country has amongst the highest rates of prematurity, small babies, stunted child growth and developmental delay worldwide, and this leads to a huge loss of human potential. There is need to do more and want to make changes, but there's limited understanding of how conditions during pregnancy and early life impacts the health and well-being of the children and later as adults. We need to understand how a combination of factors, for example, the genetic makeup, the parental health, the environment, the infections and nutrition impacts child growth and development of long-term physical and mental illnesses.
At Malawi Epidemiology and Intervention Research Unit, we are joining with other researchers to set up a unique multi-generational family birth cohort in rural and urban Malawi. This will give us a way of identifying causes of long-term ill health, and in the future, help us and other researchers develop effective interventions to prevent or treat these conditions. We are recruiting pregnant women and their partners during early pregnancy. We follow them up until the baby is born. Once the baby is born, we recruit the baby at birth, and we follow the family at 1 week, 6 weeks, and 16 weeks. At all these time points, we are asking detailed questions about health, life experiences, behavior that affect health. And we are also taking physical measurements. We also collect blood samples and other samples for health research studies now and in the future.
As you can see, Lilongwe is made up of various types of communities, some grand and others not so grand. Our focus in Lilongwe is the stories of families in Area 25, one of the peri-urban settings in Lilongwe, the capital city of Malawi. Chilumba is a rural setting in Karonga district, north of Malawi, about 500 kilometers from Lilongwe. In this episode, women from Area 25 and Chilumba will be sharing their journeys to motherhood and their experiences participating in Generation Malawi. Some of the footage has been captured by the women themselves, some by our field workers and some by a professional videographer. In Malawi, every pregnant woman is expected to start going to the antenatal clinic as soon as they confirm pregnancy.
Ndilazindikira kuti ndayembekezera ndinonyamuka kulira kuchipatala ku sikelo and ndidapita ku sikelo kuja tisanayambe china chonse chokhuza sikelo kunabwera mmodzi mwa masipala a Generation Malawi and anatolera mabuku amene tinali okhuzidwa kuti tikuchokera ku 25 anatero anatipasa timaujeni timasatifiketi takuujeni tochokera ku Generation Malawi kunena kuti tikamaliza za sikelo tiyenera titani tikakumane ndi mamembala a Generation Malawi and titamaliza za sikelo zija tinonyamuka kupita ku ofisi ya Generation Malawi anakatifotokozera chinachi chonse choyenera chimene tingathe kutani kusatira mndondomeko imeneyi choncho tinanyamuka kunipita ku nyumba siku losatira anazabwera ku nyumba kuti tisatengera mamembala a Generation Malawi.
Bodi tukulanga muli ndi mapera mwatutomina ulesi ndaizi ndafuna kudya ndopanga nzeru then nazapita kuchipatala cha ku 25 sekta 1 ndikumene anatuza kuti amukagule yani kwayezera mimba ndinokuti atikhera then napita ku pharmacy kwagula kwayezera mimba nditadziyeza paja ndakapezeka kuti ndili positive.
March ndinazoefaudi ndigawa nkhameneyo ndimapanga ndimati ndiyasima ndimaona nzeru mapanga sokutuma ndimakuganiza zina zake zimakhala kuti munthu akufamana zina ukasanza mungana ndikuyembekezera ndena gazo ndibe ukayisisimi ndeanango ndikile kuti ndioneka ndendatala zinaambezizirani zikubitirira ndenakandakayisisamiima sinajilandira bwino nasangalalaso ndibereki mamamuna simwina ndendeyimina yakotokawa mamamuna.
Ini ndimo kuponwa chimwe kunani kadongeranga kuti vanyani wosanga kubikira rumoza ndonibirwa nevana vavuka navamwari ini tisine kokesi munhu chiuda ndipasira apo chiuda ndidangirire mwana uyo andipase napa nani ndizakamutumiti sikulu ngoni kuti kavanyituma education vana vakuenda ule ndikunenga panga ntwauli kuti mwana uyu nani anganivuyira kwekupepa chiuda kuti ampasi chinjepo cha mtengo wapatali kuti nani azakantekereke kuti maji andikumbukeni kuti vamama ndivapuliri pankava chapiri nani kuva ngati nani chitandipasa
ndinaivomereza pantaimene ndisaitika kumabe ndinalokhulupirira chifanana kuti malingero amene kawalingalira nthawi inalephera kukwanisa naini malingero kuti ndithe kuthandizana anga kufuna mwati aphunzira.
My name is Kamanga-Wawanya and this is my wife. We live in area 25C. We are expecting a baby. My wife is pregnant right now.
Nakanga kwera mwatsi zimosa wozekere then alifika wabili
ine nkhamanya mwezi wa March 2023 yeniyi nkhalera nga masindano ya kulasa yala ya miezi 3. Sono pakulasa masindano yala mbwe mnyumba tikagwirizana kuti nileke danga chifukwa mwana akula. Sono pa chifukwa ichi nkhanaleka February kulasa masindano yala mbwenu March nkazasanga kuti detiranira June. Lara tira June detirira nkalindizya nkasanga mwezi wa Malawaka na masaina yankayawonanga ndekani nkhamanya kuti apa sono ndina ntumba. Ini ngaya chipokerera makola ndakuteso mbanja mwitu tikaya bakondwa chomeni chifukwa chakuti tikapulikana kuti masindano ya kulera ndireke danga.
Kuti nditenge nawo mbali mu Generation Malawi anthu ofanana ndipeza kunyumba amayendera ngati kalembera amakufusa kuti nyumba muliko anthu angati komanso mumadyashani madyaka ngati pa tsiku zonsezo timayankha mafunso.
Kafukufukuyu ngati na njira chakwamba ngati ndata kusikelo kula ngati anafumu vani vakatituma kuti tikapimishi daningi HIV tikapimisha kula tose tikasanga tili makola waka tikafuma kula vakatengi ndiruti kusikani nkharuta kusikani kula vakaniphalira kuti mwana uyo ali mukati uyu ali makola waka akhala makola waka kuzamchira mu Novembara uyembekezere kufuma pa date la nambala 1 mpaka pa 7.
Mene ndikorokozera ine mene ndinajikisera ananda zoti Generation Malawi ndikubaba wanyukulira ku Malawi komanso mene amaezera matenda amafuna kuona matenda amene mayi ndi mwana amene ukuyembekezera matenda amene mungapatsirani
Mene amandendera Generation Malawi ndinali ndi oyembekezera miezi 7 mimba miezi 7 inata ndipeza Generation Malawi mana ndifotokozerera nene kuti ndiwo akupanga kafukufuku ona kubadwa ndikula ku Malawi chimenenso chinandisangalatsa kuti ndilowe nawo amandiyeza mafupa anga mafuna aone kuchuluka kwa mafuta anga nthupi komanso kaganizidwe kanga komanso amatenga magazi aja makaiza matenda osiyana-siyana amati siyedze kumene kupezeka mchani magazi foma kupezeka matenda osiyana-siyana opatsira ngati mwana athu amene tikumuyembekezera. M'malingaliro mwanga poyamba ndimachita mantha chifukwa munthu utenga magazi timati akagulitsa anantenga chibuti chachitatu njene ndinozoti ndimayembekeza mlingati machibuti tatu akuti ayika abwerera magazi ngati sindimwa magazi makhala akuya kuti ayiso musadandaule matizathandiza nini tizobweretsera ndenangoti atenga ndichitike nchomwecho chidede chimathandiza kubweretsa magazi msanga nthupi zimasiyana ndi mankhula kuchipatala ambiri timazi chidede olo masamba amapeyala amathandizaso kwambiri magazi.
Pregnancy is a lot of work. The women ensure they take time to relax. Playtime is over. It's time. As the women engage in various leisure activities, in the back of their mind, they're thinking about how they need to prepare for delivery and the coming of the baby. For some of the women, this is a wonderful, joyful, and exciting experience. But for others, a stressful one. There are many things to consider, many ways to prepare, and several things to buy in anticipation for the new arrival. For some of the women, getting everything that is required in preparation for the baby's birth can be daunting.
Vinhu hivi vakulisira ntchito napo namuyembekezera kuchipatala. Apa pali kapelo. Pelo iyi ndakulisiramo ntchito shati ya matherera. Then mukati mwa pelo muli mapepala ayotamiyalanga pasi panyengo ya kuchilira. Palatamala apa pali salu izi muzionapo. Salu izi tikuyalanga pasi pamapepalawo yakulisira ntchito. Then muli masalu sikisi. Salu izi zakupokelera bebe balatafuma kuchipatala. Balatapokera bebe tinava kuyembekezera vidoko tinati mabuti aya apatamumveka tinatokuyembekezera vidoko tipewa na vinyake vikwiza apo tikwamba kuwaka.
Join us again for episode 2, where we'll be looking at the birth experiences and the first stages of life, and episode 3, where we will follow the families and see how they have adjusted to the new additions.
Just mention
Thank you so much for watching, and just wanted to acknowledge our Professor Rob Stewart. He should have been on the list. Apologies, Rob, we're working on it. Thank
so
you.
important, we forgot you actually.
Yes, I'd like to introduce Dr. Sharifa now. She's going to talk us through the process of making the film. Dr. Sharifa.
Yeah, I don't think so. People don't look quite as interesting. Okay, so I'm generally a storyteller. So in typical terms in Malawi, we start with Padango Kala, and the Malawians will respond, Padango Kala.
We don't say.
So in equal to something like once upon a time, except in this context, we're waiting for a response, which indicates generally our way of storytelling as a participatory one, as a collaborative sort of experience. And that aspect also informed the way the film was conceptualized, the way the design was, and as a collaborative storytelling experiences of the women's experiences work in Generation Malawi, but as well as their lives at home, different aspects of their lives at home. And so, how did we do that? We had initial consultations with communities that these participants are coming from, both Lilongwe and Area 25. The idea of the consultation was that they do not live in abstraction, they live within a community, that perhaps we wanted to understand what that context is outside of the medical interactions that we have with them. We also wanted to understand and gauge, well, feel for what a film, how people would react and respond to a film. And there were questions there around, if they were watching a film about growing up in Malawi, what would they be expecting to see? And contributions from local leaders, from some religious backgrounds, cultural custodians, as we call it, and local members of the community's fathers, mothers, grandmothers, was also integrated into what we call a consultation report. We generated a consultation report. That is what informed the general basis around how to negotiate that consultation report, the views of those communities, and the idea of sharing their experiences, which was guided by what the Generation Malawi was doing as well. So as you can see, there is a mixture there of Generation Malawi protocols, the study itself, what it was doing, and there's also issues around how participants experienced some of those processes, as well as their lives at home, their joys, and so on and so forth. And so, to prepare what you have seen here, we had a workshop whereby, as you can see, it's video voice that was used here. Participants were given phones to document their own, to tell their own stories, to share what they would like to share, what they would like us to have a peek into, what they would like to offer for us to share, and what stories they wanted to share with the outside world. And to do that, we needed to give them some support because some of them had never used really a smartphone before. And that support meant we had a workshop to sort of work through the technicalities of how do you capture, how do you sort of, all those technicalities, which I'm not going to get into because I can see that people are bored and want to move on to the next one. So that training workshop focused on that and also working with field staff, getting to know the team and so on and so forth. So from the consultation report, the idea of who should be engaged in the film, what sort of characteristics should we be looking for? People looked at different stages. There are people who are married, people who are not, people who have expected the pregnancy, people who did not. There was the issue of age. There was the issue of whether people were the first-time mothers or not. There was conditions, economic conditions that were considered when bringing this team of 20 people into the Generation Malawi, growing up in Malawi specifically, film project. After that, after the generation of the footage was done by the, it's already explained by the participants, as well as some field staff, as well as professional videographers. And I'm sure you can tell that, oh, that one was by a participant. That's probably field staff. That's a competition. So after that, we came together to view the footage, some of the highlights in the footages that the participants had read together with the participants and think about what would be the story we want to tell. This is what we have. And then from the story we want to tell, what footage or what is missing that would help us tell that story. And together, we collaboratively created what the general storyline would be with the participants and the team of creatives, which is the post-production team, editors and so on and so forth, and myself and Marcia as well. We went into looking at how does this materialize. And so we came to that. The post-production as well has been a constant dialogical process, a participatory one, a journey, just like the storytelling experience, whereby a negotiation between the filmmakers, as well as going back to the participants, as well as Generation Malawi. So it's been a collaborative process, really. Just as collaboratively as you are looking at me now, except I'm the center of attention. Then the participants' experiences and stories was the center that guided us to move into exploring what we have explored. I think that is it. So how do we say bye? Oh, bye-bye. Introduce the second episode.
Ah, yes. Second episode. Oh, we are looking for that one, isn't it? We are going to be watching the second episode, moving on from the first one. I don't want to say much about it because it's already said in the narration, so I don't want it to be repeated. So please do enjoy the second episode. Thank you. No one cried like that.
Thank you so much. We're going to move into the next segment, which will open for comments, questions, and any contributions that you might have. I'm going to call up our panel, Prof. Mia, Prof. Andrew McIntosh. Are you joining us now? Prof. Robert Stewart, Dr. Wisdom, Dr. Sharifa, and all come to the panel. Right, Chad has a mic there. If you have a question or a comment, you can just raise up your hand.
We don't have two roaming mics, but I think if you speak up, the mic is there in the owl, people online should be able to hear you. Small space here.
So maybe just before the questions, we can just introduce the panel. So you've kind of heard from most of us. So Andrew is from the University of Edinburgh, Centre for Brain Sciences. psychiatric genomics, psychiatrist, etc. And is the PI on the Generation Malawi study through the UKRI award. Rob Stewart, also University of Edinburgh, is actually the brains behind the entire Generation Malawi study, I would say, it's fair to say, and certainly led it through very difficult periods. COVID came along just as we were trying to get started, which was really quite unhelpful. But yeah, has put in a tremendous amount of work over the last 4 or so years to actually get us to where we are. Wisdom was recruited to lead the study in Malawi, which she does very ably with the support of Juliet Malawa, who you saw on the first video, in Karonga, and Providence and Ndindi, who you haven't seen yet, who leads it in Lilongwe. Neither of them are here today, unfortunately. I'm the director of MEIRU, the jack of all trades, but I'm involved in the Generation Malawi study. And then Marcia, our public engagement officer, who's been very involved in this work and was recruited through the Wellcome Public Engagement Award, and Sharifa Abdulla, who we're very lucky to have, who's now a lecturer in medical humanities. Theatre Performance Studies at University of Glasgow, but was in Malawi when we started this, which was fantastic. So we have engaged with her as a consultant on this whole process, as you've heard. So probably Generation Malawi, the study questions, some of us, and then more questions about the actual documentary, Marcia and Sharifa. Anyway, thank you, please.
Right, thank you. Just a little bit low, that way wisdom can come in. I think maybe the camera should grab you all there. I should speak.
Great, do we have any questions? Yes, please.
I thought you were going to need the camera. Good afternoon, my name is Marilyn. I'm a PhD fellow at the University of Edinburgh. And I'm using MEIRU data for my analysis, so this is very interesting. I have a couple of questions / comments. Are the Generation Malawi participants also part of the health and demographic surveillance system? And is there any compensation for the families? Do you manage to recruit fathers for every birth that you register? And what happens with pregnancy outcomes that are not live births?
Thank you so much for that, for those comprehensive questions. To begin with, yes, the main thing that we try to do is recruit mothers who are in the demographics surveillance site, both in the rural site and even in the urban site. So that's one of the eligibility criteria for being enrolled in the study, and we did this particularly to make sure that we can do linkage of the data being collected in the birth cohort with that collected in the wider DSS as well. So that's a really unique point of the study, that we are able to make those linkages, not just with the mothers and the babies, but also and the partners, but also even in the rural site where we have data ranging coming from 1970s, so we can even make those linkages up the family trees as well. The compensation, yeah, we do reimburse participants for transportation, which has been encouraged, especially when they come to the clinics. Of course, we try to put a balance between reimbursing them for transportation and also not it being too high, that is coercing the participants to take part in the study. So the amount are reasonable considering how much transportation costs to go from their homes to the clinic and back. I think that was the other.
To recruit fathers for every birth?
Yeah, so the goal is to recruit all the fathers who are in the study as well. I must say that's been one of the main challenges of this study, not just the birth cohort study, but also all forms of research, not just I'm sure in Malawi, but elsewhere as well, getting the men to take part in the recruitment area. I think in the recruitment in the study, it's a lot better in the rural side. So about 70% the fathers also, that's somewhere along there, of the fathers are taking part in the study in the rural area. That's because even the location of where the husbands work is in the DSS as well, so it's easy to reach them. Whereas in the urban site, as you can imagine, it's a lot more difficult. So it's a lot less with men taking part in the urban site compared to the rural site. And then the last one.
Pregnancy outcomes that are not live births.
Yes, so I think as we noted in the footage as well, there's lots of activities which should take place, even for those who have had a bad outcome. For all the babies in the birth cohort, we conduct the delivery questionnaire. So that's one thing which we make sure that we have that questionnaire, even if those who have had a poor outcome as well. So all of them have data for the delivery. So almost all the babies in the study. The ones who have the poor outcome even depends on when it actually occurred. If it happened at labor, usually been soon after delivery, and the samples able to be collected. So we have those placenta and cord blood samples for those babies who even passed on soon after delivery as well.
But for the babies that are lost before the pregnancy losses, we do we track them. We track the mothers. We know if they've missed an expected visit or not turned up for delivery. So we will keep in contact with the mothers to find out what happened. Necessary.
Thank you.
All right.
Thanks very much. That's absolutely fantastic work and fantastic films. I was interested in the section where the newborn was being put in the pea pod, and the grandmother was wondering about these satanic rites. And I just wondered, in relation to sort of the culture in the villages and so on, how much work you had to do to overcome suspicion on members of the communities. Thank you.
Do you want to say something about that?
Could do, yeah. So we did some specific work on that, particularly what we would call non-invasive sampling, so taking sort of saliva or hair, and did a lot of kind of focus group work, some very good sort of social scientists in the team, and indeed there are a lot of beliefs around, for instance, witchcraft, that people might use the baby's hair to cause harm to the baby. But what came out of it was if you do lots of explanation, engagement at multiple levels in the community, so which is something that MEIRU is very good at. So engaging the sort of the chiefs and other sort of decision makers, but then engaging and explaining and listening to the mothers and families themselves. And after you do that, I think the take-up of these things, including being put into what looks like a little spaceship for the babies, is actually very good.
Thank you very much.
Yeah.
Thank you.
I might have missed this, but I just wondered what the logic was in choosing Kamanga as a rural, or the particular rural area, Kamanga. I say that actually just because some of the villages that I was working in, which was much further south near Rwanda, because when I was on a BSO project, seemed more rural, or should we say more. The men in the study seemed much more a little bit more westernized, shall we say, or less the sort of traditional views that we've had. Yeah.
Thank you. Yeah, we work in Karonga. We've been working there since 1979, so it's in the context of a health and demographic surveillance site. So we have got a lot of work, so everything is nested within there. in terms of the development aspects, I mean, Karonga community is not as poor as some of the communities in the south, but I wouldn't like you to take away the impression that all the dads are like the ones up here in the film. There's a massive selection bias in terms of the men who want to be part of this and who've been actively involved in this process. So the three guys that you saw, yeah, they wanted to participate, they wanted to talk about their wife's health and their role in it and so on, but that is probably not typical of all men in Karonga, I would say. Yeah, thank you.
Oops.
Thanks very much. Just leading on a bit from that, I just wondered if you could explain who the audience is for the films and what it is that you're wanting to achieve through the films, whether it's part of your reporting to funders or whether this is a more general information for people. Because I do think whilst it's wonderful to see this evidence of positive masculinity in Malawi, I'm not, just like the last person, I'm not sure, certainly in with the people that I work with, that is actually as widespread as perhaps it seems from this film, and therefore that contextualization, I would imagine, would be really important for people who are not as familiar with Malawi. So not just the positive masculinity one, but also this availability of mental health counselling, which is obviously fantastic that you offer that. Again, I'm not sure that's a widespreadly, sort of widely available, and could that perhaps affect other projects of people who feel that there's a real need in Malawi for that type of support. So just really around that contextualization and who's the audience for the films.
They spin the mic.
Yeah, thank you very much. I think that's a really important question around contextualization. And yes, the film itself, even when you looked at it, you would see that there are around 20 women, and you've only seen about 3 fathers or 4 fathers, which is actually reflecting the question that you're saying, that the context itself, the absence is also part of the storytelling in this case. And we do agree that not everyone has got a positive masculinity, even from a cultural perspective. And because mostly they are away doing other things. And some of the parents we have, the mothers we have here, were not exactly married and did not have an active figure. But this is also part of a process. We are now on episode 2. As we are moving to episode 3 as well, we'll be looking at how some of these might come into focus. In terms of setting who the audience was, my understanding as well from the team's perspective is that this is a public engagement activity which focuses mainly on a larger sort of more global sort of audience for now. And that's why perhaps some of that contextualization might be important, which we did when describing about loss and the children and things like that. So I think moving forward, we will consider thinking about how might we contextualize, but it might be difficult in a film of 15 minutes, 20 minutes to contextualize every single aspect. We're hoping that this will trigger something for us to go reading some more on the project and on the context of Malawi. I don't know if I helped.
Yes, I was perhaps going to raise that also within the same public engagement funding, we have done a bit of work on women with maternal health issues, and I think that probably picks up some of the vicissitudes of their lives. So maybe Rob can say something more about that. But I mean, these films will be publicly available, but they're not being branded as this is the universal experience of all women in pregnancy in Malawi. It's about people who are interested in the Generation Malawi birth cohort actually being able to see some of the women in it, rather than just looking at the data or accessing samples and so on, so that to give a face to some of the people in the data. Do you want to say something about the?
Yeah, so in terms of this public engagement, there's another work package where we're creating 7 short films around around maternal mental health, with women telling their stories of the difficulties that they've had, and the key things that come across in those, and also in the clinic, is that the major stressors are intimate partner violence, poverty, and lack of social support, and physical health conditions as well. But I mean, I think it is important also to have films like this, which do show the positive experience of a lot of people in Malawi, which often sort of, life is hard, and sometimes I can imagine the Malawian audiences, I think, would look at this and find it quite sort of enjoyable to watch their experiences being shown in this kind of format. And in terms of is availability of counselling, absolutely. There's the friendship bench counselling, which is problem solving therapy, which is offered through the clinics, is great for these participants, and it would be wonderful if that kind of thing could be shared more widely. And one of the outputs from the project has been a maternal mental health manual for healthcare workers in Malawi, which is just yesterday, in fact, was signed off by the Minister of Health as an official MOH publication. And that will be able to be distributed throughout the country and start as part of a process of raising awareness around maternal mental health, and hopefully provide improving access to free counselling and other mental health interventions across the country. Yeah.
Do you mind if I just say something very briefly? I think the video you've created is extremely powerful, and it's really interesting and compelling watching these stories. I would just, in response to your question, I mean, in the UK, there have been a number of birth cohort studies funded, and they've been funded in other countries. Predominantly, these have been rich countries, and they've been predominantly European ancestry or white populations. This, I just wanted to say, this is a really rare and unusual resource here for Malawi, but also for the world. Funders have shown great vision, I think, funding Generation Malawi and the context of the research in Malawi and the demographic surveillance science. And it shouldn't need to be said, but I think most funders are interested not just in the health of their own populations, but of global populations. And if you're interested in improving the health of global populations, you've got to fund global health and birth cohort studies. And this is an example, a really precious and valuable thing, a great thing to have created this video. So, and I wanted just to end, I think it'd be really remiss not to thank you, Mia, for your leadership of the work as a total. Mia's been very generous in thanking everybody else, but I think we also need to thank her for her leadership too. So thank you, Mia.
Much. Gosh, I want to really commend you. It's an amazing study. I don't know Malawi, but I've lived 35 years in Kenya. And my background is I'm a PhD student or past student from Edinburgh University in the Faculty of Medicine. I'm a physiotherapist. But I've worked with infant massage and childbirth education in Kenya as well. So I actually had two questions. One was about the study design, and part of it was spoken about the actual selections of the two areas, and whether they were selected or whether it was a random choice or randomization. The other was as a descriptive prospective study. When you collect the data, I'm assuming therefore there's no intervention if you find alarming results, so that there won't be any, because it's a descriptive study, so that's a hard one to be doing. But it reminds me of the adverse childhood study from Permanente in America. So this is amazing that it's happening in Africa. Well done.
So, yes, I'll let Mia talk about the sort of side choice in due course, but we do intervene. I think it's sort of only ethical to do that, and there's definitely a requirement of getting ethical approval. So both for the non-communicable disease element, so if your blood pressure is above a certain level, then you'll get referred to an NCD clinic that's set up by MEIRU. And similarly, if you're reporting anything like suicidal ideation or high scores on some of the mental health measures, then you're referred to the mental health clinic for assessment and treatment. We are collecting the data on the people who are attending the clinic, so hopefully we'll be able to take that into account when we're looking at the sort of long-term outcomes. And also, obviously, if they identify a very sick baby, then there are protocols for getting care. So yes, we do intervene, and I think it's actually right to do.
Yes, so in terms of Kamanga, we're there because we've always been there. In terms of the site in Lilongwe, when we decided, when it's about 10 years ago, when we started to do work on cardiometabolic conditions, and we wanted to set up an urban equivalent study platform, because at that time the received wisdom was that these were urban conditions, etc. Absolute nonsense. You know, the rates of hypertension in rural areas extremely high, diabetes would be high, except for the high mortality. And so when we moved to Lilongwe, when we wanted to start something in Lilongwe, we had a very large workshop with all the stakeholders in the Ministry of Health. We described what we needed. We wanted a clearly geographically defined population that we could track over time of a certain size and so on. And there's a lot of discussion about various areas in the Lilongwe, and they were keen that we go to Area 25. It's a very busy, rapidly growing area. There's a lot of rural in-migrants, which has their own problems. It's got a lot of casual workers for the tobacco floors, big health problems, and they wanted to expand services there particularly. So the fact that we would at that time be prepared to set up an NCD clinic for hypertension, diabetes, they directed us there. There are other enhanced services in Area 25. Baylor Health from Texas Children's Hospital have a project in Area 25. So interestingly, it's actually more like a district hospital now than a health centre. They can do cesarean sections there. They've expanded their maternity wing, which is actually fitted in quite well with the Generation Malawi birth cohort, because it means it's much easier to track people, even if they have instrumental deliveries or C-sections, whereas before they would have been sent off somewhere else, but they're there in the hospital, so we're actually able to capture data on those ones as well, which is great. And just to say, in Chilumba, if people are referred for C-sections, they go to the district hospital. So we've got all the staff trained at the district hospital and actually have staff members based there to do the child follow-ups if women are referred for delivery elsewhere.
Great, thank you. Shall we take one more question? Oh, do we have any questions online?
No. Online, the question was again about the remuneration of the participants. So I refer back to the recording, but if you wanted to explain it again quickly, but.
Yeah, it's not just transport. We do give some compensation for time for the house. We do give some modest compensation for time at the household visits, because that is quite a involved event, and so people have to take time out of their normal lives on those days. So for each of the participants, mother, father, and mother on behalf of the baby, we do give them some compensation for time. But as Wisdom says, we have to pitch it right, so it can't be in this per community, so it can't be seen as a undue inducement to participate, which is a fine balance of being fair and not being in a position where people are only participating for the money.
I was interested to know what your experience is with teenage pregnancies. We didn't really see that many of the women being young, you know, 16 or so. And thinking about the significant others of girls of that age, is there any attempt to try and bring in parents and get the story around that? And also the life story of girls who are of that sort of age, 14, 16, who've become pregnant. Are you capturing that, or are you trying to capture that?
So the eligibility criteria to take part in the birth cohort is 16 years of age. So for those who are younger than 16, they're not eligible to take part in the study. And even for those ones who are 16 years and older, they have to be emancipated minors as well. So we get for those who are 16 years and older, they have to get approval from their guardians, and even for them to assent into taking part into the study. As you noted in the video, about 2 women who took part in the study were teenage pregnancy, those in that age range. So there is a large amount of women who are younger than 18 years old and who have taken part in the study. One of the things is that we also ask them, for all the participants, we ask them if they're willing to involve their partners into the study or not. So we also get, for those who are sent, who approve for us to approach their partners, we also attempt to recruit their partners into the study. But getting the parents' experience, that will be one area which we can add on into the study, because you're right, most of them end up living either with their parents or with their partners as well. So that might be one area which we can improve on, getting the perspectives of the parents who are looking after their teenage children who are experiencing pregnancy.
Just to say, one of the women in particular in the study is extremely young, but sadly she was one of the ones who lost her baby and left, so she won't be featuring in future episodes, but she was extremely young. And just to say, the issue about contacting partners or the fathers of the pregnancies and under 18s has been made more complicated in Malawi recently, because it's now a criminal offence to have sex with a girl that's under 18. Which is intended to, deter teenage pregnancies, but unfortunately, one of the unintended consequences is that if a young woman does become pregnant under that age, the father is now denying it and not taking responsibility and not supporting, because they're actually in fear of being prosecuted. So it's a situation that comes up around Generation Malawi. We do have protocols and things for if, we are aware of criminal events related to women in our birth cohort, whether it's intimate partner violence, rape, or other forms of harm. And it's, we do have difficult decisions to make sometimes about how to ensure the risk benefit for the mother of supporting them to report or deal with it within the community or with the actual police and so on. And it's a situation that is not infrequent.
Thank you.
We have one final question online. Angie, who's online, I'll just read it quickly. I was struck by the amount of extra work for the hospital, the clinic hospital staff, both in training and testing. How was this issue dealt with?
Yes, so we do, and we did a lot of training even before we started recruitment, and even we do a lot of refreshers as well, training the nurses and the staff at the government hospitals, so that they know how to the procedures relating to the Generation Malawi birth cohort. So yeah, all the things that you've noted, those are all the activities which were trained to do once they see that the mothers have come in and were part of the Generation Malawi study. One of the things we do as well is we have an agreement with the nurses and also with the hospitals themselves, where we give a little compensation, which is split between the nurses and the staff who are actually taking part in the in the procedures, and also the other half was usually to buy some of the things which are necessary for the labor ward and the hospital as a whole. So yeah, there's another agreement between the MEIRU team and the Ministry of Health team and the nurses at the different hospitals, just to incentivize them into making sure that two of the procedures necessary as well.
Hand over to Stuart.
All right, thank you very much. Thank you to our panel for answering questions and all the questions that we had. Stuart, did you want to say something?
I'm going to come up in a second.
All right, thank you. Our panel, thank you very much, and for all the questions as well, and to the members online, thank you. Luggage.
Well, I think the level of interest and appreciation for the films is shown very clearly in the engagement in the Q&A session there. A few words of brief thanks. I think it's been a real privilege to share in these real life, intimate insights of the women and their families featured in these documentaries in the Generation Malawi cohort. And I think also the participatory storytelling collaborative approach that Dr. Sharifa spoke about comes across really strongly, and the engagement that's gone with the different members of the community that was also explained in the negotiation consultation process, really giving great agency to these Malawian women and some of their partners and family members to tell their stories in their own words, and giving this great wealth of data that's been gathered with the interlinkages that we've heard. It's fantastic that the Generation Malawi birth cohort is taking this long-term commitment, and perhaps the longest term, I think, Professor Crampin was saying as well, and fantastic to hear of the announcement of additional 4 years funding from UKRI. Those of you here in person in the room are very welcome to stay on for more conversation and Malawi coffee. Thank you very much to those of you who've joined online. And the videos are going to be made available online shortly after these screening events as well. Well, please let's join together in thanking the participants first and foremost, who are telling their stories and sharing their truths from Malawi, and also to our presenters today and some of the key members of the team: Marcia Kamanga-Wawanya, Professor Crampin, Dr. Wisdom Nakanga, Dr. Sharifa Abdulla, Professors Andrew McIntosh and Rob Stewart. Also to the Wellcome Trust and UKRI for the valuable funding, and also to my colleagues in the Scotland Malawi Partnership for collaborating so constructively with MEIRU. So thank you very much indeed, everybody. Thank you for coming. Thank you for joining online. Have a very good afternoon.